I'll go ahead and call this meeting to order of the Incarceration Prevention Reduction Task Force, and you are joining the Behavioral Health Committee this morning. We meet until 10:30, and today is November 16th, 2021, and we are meeting remotely. Before we begin, we acknowledge that we are gathered on the traditional and unceded territory of the Lummi, Nooksack, Samish, and Semiahmoo people who have cared for and tended this land since time immemorial. Truth and acknowledgement are critical to building mutual respect and connection across all barriers of heritage and difference. We begin this effort to acknowledge what has been buried by honoring the truth. We pay respect to their elders, past and present. Please take a moment to consider the many legacies of violence, displacement, migration, and settlement that bring us together here today. And please join us in uncovering such truths at any and all public events. Well, again, I want to welcome everybody. And with that, on our packet, we do have a decent amount of time for discussion today. And Chair Member Hamill and I are going to add one thing into your agenda, but we're going to try and keep pretty much to it. So the first one you will see is Task Force Communications. And just a brief bit of context for you all. This is kind of coming back onto our agenda. We talked about this a while ago when we wanted, we've been talking about how do we get the news, right? Or the happenings of the Incarceration Prevention Task Force out in front of people. How do we do that? So this is kind of this committee's priorities for what that messaging should contain. And the way we broke it down, just to refresh folks' memories, because I think this is about 2 meetings ago, the way we broke this down was each subcommittee would come up with 2 to 3 items that they thought were really important that we wanted to lead off with. This didn't have to be the be all and end all. This doesn't have to be a complete, marching order for the entire communication strategy, but it should be maybe those things that we think as a group are pretty important. So with that context, and Jill, I'll just ask you to just chime in. Did I miss anything in my kind of context setting there about our marching orders for today on this?
No, you did well. Thank you, Mike. The 3 or 4 items that we're asking committees to weigh in on are particular communications campaigns, so to speak, messages that the task force wants to get out to the community about its work, that we hope to have a communications consultant develop into a more of a full-blown campaign.
Okay, so with that, I'll go ahead and open up the floor if somebody wants to, someone's got something burning there.
Mike, I don't know if it applies specifically to the Behavioral Health Subcommittee, but certainly the Crisis Stabilization Center, just information, utilization, that sort of thing might be a consideration. We talked about the Crisis Stabilization Center Subcommittee meeting quarterly, and also being prepared to just provide information to the Behavioral Health Subcommittee as well as the Legal and Justice Subcommittee relative to utilization of the Crisis Stabilization Center. I don't know if that reaches that level of a priority in terms of communication for Behavioral Health Subcommittee, but I offer that thought.
I think it's a really good one, Perry. Thanks for that. I might tack onto that too, Perry. One of the things that we've kind of come about thinking about our facility, and now as it's come to full utilization, we're also realizing what else we need, what else in the continuum, maybe what is the next step. So I think sometimes those advancements lead us to the next advancement. And I was reviewing the recording of where we talked about a mental health center, right? That for that center that covers those things outside of that. So I think it's an excellent point, Perry. Dan?
Can you guys hear me?
Yep.
Okay. Sorry, I'm on a phone and a computer because I was having a lot of difficulty in logging in. I think just kind of going off of what Perry just mentioned, service capacity for behavioral health treatment in the community would be a good idea for us, I think, as an agenda item just for a future discussion, but also once that gets fleshed out a little bit, to be able to communicate that out to the public. What are the options? We've got, for example, Lake Whatcom treatment. We've got the Crisis Stabilization Center. I just met with local 106 rep last Friday. That's the Bellingham firefighters. And that rep was saying that the Crisis Stabilization Center is full. And so I want to understand what the impacts are for first responders in terms of having a place for people to go. I'd like to communicate out the intricacies when it comes to ITA complications for involuntary treatment and what that means for people when they're experiencing a behavioral health crisis, and if they're not able to get the interventions that they need, what happens to them, So I think that's, so service capacity and all the details around it.
Under Sheriff Chadwick.
I think maybe just highlighting the intersect between all our first responders, whether it's law enforcement, EMS, fire, and our behavioral health resources, and what we're doing, whether it's the program in Bellingham, what we're trying to get up and running out in other parts of the county. I think that's important. And then kind of reiterating, I think there's some misunderstanding that law enforcement can't go to those type of calls, and we certainly can. Obviously, there's some additional steps we need to take and under the duty of reasonable care, but I think that message is lost somewhere in the translation, and there's this perception now that law enforcement has stopped going to those type of calls, and that's not the case. But we need to highlight what we're doing collaboratively with behavioral health, so that we're trying to bring the services to where people are in the most expeditious manner.
Yeah, definitely, Doug. Thank you. That's very well said. Arlene, I think you have your hand up, and then Stephen. Arlene, I think you're still muted.
Okay. I like what Jill said about offering 2 to 3 options, because I would like to see the communication very spare, simple, clear, non-jargony language. It's really important, if we want people to read it and go through it, that they feel comfortable going forward. And so paring it down just to a few things, I think, is really important. Of course, crisis stabilization. And I like the suggestion of what we're moving to next, because we need to have resources for law enforcement and all emergency services to bring people, but also we need a place for people to go in an emergency. So putting the next possibility of a 24/7 urgent care center would be ideal, I think, if everybody supports that. What I like about that suggestion is the fact that all sides of the issue are supportive. And I feel like that's really important to get things done. As far as the Law and Justice Committee is concerned, I think the things we need to name in from that committee are the things that have made the most difference in criminal justice changes that have been made over the last couple of years. And I'm really not sure what we're going to choose for that, but I suppose the measures that are keeping people from being jailed are terribly important, and we have done some of those. So that will be on our list, I'm pretty sure.
Thanks for that, Arlene. Stephen?
Just expanding a little bit on Doug's suggestion, I think the range of services that we've created and are rolling out to respond to on the ground needs. I suspect that some people have heard of GRACE and maybe a few more of LEAD, but they probably don't know what they are, how they work, what the different populations are they're shooting for. They don't know that the city is piloting an ART program. So I think there has been some desire for that from some parts of the community, and to know that that's being considered would be important. And then just yesterday, when the task force approved an impact like ride along co-responder kind of program, and I think that would provide some context to deal with the complexities of unarmed versus safety kinds of concerns that we're trying to deal with, the issues that arise from responding to incidents that are in outlying areas in the county. You know, I think there's a way in surveying those multiple program initiatives to talk about some of the hurdles and some of the complexities of what this committee is trying to do.
Mike?
Yeah, thanks. Good morning. Just catching up on the conversation, running on generator out here. So it's a little slow. I would offer that Jen Mason's done some good work on that website, on the Respond Whatcom website, and that might be a good place to do some of the surveys or get that feedback and centralize that. One of the conversations we've had in other leadership meetings is how to bring all that sort of into the GRACE world, because you're right, Stephen, it's a little fragmented on all these programs that are out there. So I think the general will was to try to always, have this orbit around the GRACE program. So we might build off of that work already done with Jen Mason's group.
Heather, I see you on the call today, and I understand that Chuckanut Health Foundation is helping make Respond Whatcom happen. Could you tell this group just a teeny bit about Respond Whatcom and how you see that maybe interplaying, as Mike mentioned, with Going Future? And then I'd like to go to Chief Tanksley after that.
Yes, I can share a little more. So we have a website built, and the LEAD program actually inspired this website to be built. Chuckanut has agreed to host it, and ideally we'd love to see a dashboard on that website, and it's Respond Whatcom so that it can include programs like GRACE or alternative responses. And so there's a commitment that the LEAD program at least shares quarterly data on who's participate, at the level that's appropriate for sharing with the community, but numbers in the program, outcomes if possible. There's a strong commitment to reporting on racial diversity within the program, so that we can start to practice continuous improvement as a community. So were there specific questions or things you wanted me to point out, Mike? That's kind of a general overview.
No, I found that helpful. I just wanted to make sure we got it on our minutes, that people knew about it, knew that you were officially hosting it, and just a blurb about the content. So that's
great.
Super. Yeah. Chief Tanksley.
Yeah, so with regard to what Mike is about Respond Whatcom, as I look through that website and as we talk about other programs, what I would like to see is probably some type of holistic document, maybe a flow chart of sorts, to see where, law enforcement and first responders, where we need to go and what direction we should take people, or, who we should call and things like that. On December 6th, part of the Blake decision, as you know, that the healthcare authority was tasked with producing a preliminary report by December 31st, 2021, with the final report of December 31st, 2022. I was chosen to be a member of that committee, which we have our first meeting on December 6th. So that's a statewide committee to address the requirements of the Blake decision. So with that, at some point I would like to, talk about what we're doing here in Whatcom County for that committee, because it will be asked, and to have a document of sorts, or guide, if you will, to say what we're doing and how we're doing it. So I think that might be helpful, because for me, it does seem a bit fragmented. I mean, we're doing a lot of great work, but how do you know, which direction to go, when and where? So that's all I have.
Thanks for that. As you were talking, my right brain was getting busy, and Chief Tanks, I think you're really onto something. Just this is my personal opinion, but the work is complex of this committee. And I think you're onto something with visual, and I like Arlene's mentioning of sparse. And Jill, I know these are more themes or more maybe they're not specific topic areas. They're more like how we might get across. I just want to just lift those two perspectives up as maybe being almost as important as what we say, because I think when you think about how complex, and we think about a path of a person possibly meeting with law enforcement, and then what are the possible avenues? What could happen if that person could be diverted? They could get behavioral health services. They could need incarceration, right? There's a whole host of things. And it could be an opportunity to show where improvements have been made in diversion systems, how people are diverted, and where future opportunities are for the general public, one, to know about that are being worked about, and two, to possibly provide input. Stephen and I attended a group of various different health department sponsored committees, and many of the committees had similar issues connecting with the larger public and soliciting meaningful feedback, both for the people presenting it and the people receiving it, feedback on the work of those committees. And I just want to just lift up that sparse and visual representation of the work of the committee would be really important. Chris?
Yeah, I agree with what you were just saying about those two pieces, Mike. One question, I guess, to follow up on Chief Tanksley's comment. So is this Respond Whatcom, and Heather, I guess this would go to you, is this website more designed around reflecting data of what is happening currently? Is it more of a flow chart or a referral resource page for people to go to? And if so, do we have an idea of what that target audience would be? Because if it was, say, people like us on this page, it would be very different than if it was the public. I think if there's two, it seems like just beyond the website, it sounds like there's two things people are talking about. One is how to reflect data back, that what's going on, and the first thing is how to get that information out to people. So I know one thing we've noticed in our district is short videos right now work better than anything else in terms of parents being able to watch an 8-minute video while they're cooking dinner for their, after the long day. So I know the minute you make a video, it's usually outdated, but that seems like that if we're wanting to get it out to a broader audience, that might be a good idea. Thanks, Heather.
And Chief, I see your hand up again. Oh, okay, you removed it?
Yes.
Okay, great. And Chris, I'm assuming yours is still just up as well. Okay, all right, Heather, I see your hand physically raised.
I just want to respond to Chris, if that's okay. So the website is a great outline right now and has some good basic content on there. And I think, Chris, your idea is really important about how do we actually, who's the audience for this website, and what would they care? Why would they care about this information? And how do we make sure they're receiving it in a way that's digestible and that they will pay some attention to it in this information rich environment we're in, especially digitally, right? So what I want to say is we can make it whatever we want. There's nothing that's baked in. And so there's lots of opportunity right now to have this discussion about what information do we want on this? What's the process for how we update it? It's just the basic site right now that we have. So lots of space to do what you're talking about, Chris. And I invite that. And if there is energy around that from people, there's margin for that over on this side too. So.
Under Sheriff Chadwick.
Let me put my hand down before I forget. maybe just as you're developing that website, if you could maybe put together some infographics. You know, I'm not a big fan of reading lists and lists of statistics, but if you have some very simple graphics, kind of speaks to what Arlene was talking about, and then some basic stats. But if you can put those in a PDF so you can share them with, because a lot of this information, all of us are in multiple groups and meetings that talk about the same thing. So one, we could link to that within our, the sheriff's office obviously has a social media presence. And if we could get access to those infographics, then we could post those on our website, and then also link to the website there if people want to go back later and get that information.
Heather, thanks so much for sharing it. I'm sorry we ended up doing a little bit of an aside and putting you on the spot with Respond Wadcom. I think it's a great example, and Mike, thanks for sharing that and highlighting that to us. I had actually not seen it, and I think it could be an example. And I guess I just want to call out, which is maybe just my own value, but that it doesn't relieve us as a county task force of developing official recommendations to county staff, and we believe this is important. So I think harmonizing, using each other, leveraging that website and how it goes into the future, be seen as in concert and maybe in parallel, but not in place of. I think that's one value I've really heard from this committee and from the task force as a whole, that we think this is important enough work to do. Jill, I just want to do a quick temperature check. I know you and Jackie are so good at taking notes, and I'm in my own head, I think we've got about 2 to 3, but we might be short a little bit. Am I correct, Jill?
No, we've got plenty. Thank you very much, everyone.
Plenty of meat. Okay. If anybody has additional items, Jill, are they okay to send it to you? And by what time should they stop sending it to you if you're okay receiving them that way?
Yes, no stop date. Send me whatever thoughts and ideas you have.
Okay, super. Well, thank you for that discussion. And thank you too for the people that really talked about the process and the form and how it might be seated. I think that's going to be really, really crucial. All right, so next up on our items, and Jill, if you don't mind, it might be helpful to put the packet pages up so we can see what those priority items are. And as Jill is bringing that up, and just kind of refresh the committee's memory, we are coming back to our homework. So we are hitting the priority list that we established as a group, both the ideas and the ranking. We've made quite a bit of progress down this group, and as we go, we've actually been making some recommendations to the entire task force. As you all know, most recently on Monday, our most recent one, thank you, Under Sheriff Chadwick, about giving a little bit more definition of what we mean by alternative response and some specific wish list items. We also, thanks to Chris Cochran, who told us, just to refresh your memories, Chris made a presentation about what the Bellingham School District is doing for mental health, for support for students, but also for staff and for their educators, and how they're seeking to do that. So you can see here under G, juvenile SUD, that Chris gave us a good launching off point, but Dan and I have a little homework to do. So Perry, expect to reach out. We'll be reaching out to you and maybe Jackie to see if we can, what we might be able to drum up in terms of juvenile SUD. That was a very high level of importance put on this by this committee. So expect to reach out, and apologies to the group. We didn't do that as of yet. Where we're really at kind of today, that leaves us with crisis responses. We already covered that, is what you see as item C, which is reentry and warm handoff. I know you all got jail status reports on Monday. I know we've also talked a decent amount and touched on this subject from the aspect of there's just nobody to do the work inside the jail. So when we talk about reentry and warm handoff, one of our concerns in pointed pieces of feedback is some of the behavioral health specialists that are normally in the jail that help folks as they're beginning to depart haven't been in employ for a very long time. And as Perry tells us, that program is going to need kind of a reboot. With that, I'll stop. I know that that Co-Chair Hamill has something he wanted to talk a little bit about in terms of warm handoff. Perry, really quickly, as we're on this item again, and I know you've updated this group, what is the current status of the health department's contract, and what do you see in the future for some dedicated resources inside the jail?
Probably should have gathered just a little bit more detailed information, but I can share certainly what I know. As you had mentioned, Mike, the current provider informed the county that they were not going to proceed forward. And so the response that we did with that was to put out a request for proposal. We had a number of responders, and Lifeline Connections was the successful bidder that was chosen. Also, what the steps that were taken as Lifeline Connections is formatting and preparing to come in as of the first of the year was also to bridge the services that were needed between now and the end of the year. And so some dollars were taken from the existing contract, and a limited number of staff from Lifeline were stepping into that process. And so we've addressed that particular need. I don't have a really current update of, okay, so exactly when is that going to happen? But I know it's imminent at this point. A lot of focus and discussion around the reentry component for obvious reasons that are also occurring, and also a lot of focus and interest around the linkage with the reentry staff to our existing diversion programs, obviously GRACE, LEAD, mental health court, drug court, et cetera. So hopefully that's about as much information as I know at this point. Hopefully that's enough information, and I will get a bit more and be a bit more responsive in our next meeting, obviously, as well.
That's really helpful. And thank you, Perry, for allowing me to put you on the spot. That's really appreciated. Before we open it up to discussion, I do want to go to Co-Chair Hamill, who had a piece that he was going to talk about in terms of handoff community transitions.
Thanks, Mike. Yeah, I don't know if I have much more. I think what Perry just said is, I support everything that Perry just mentioned. I guess what I would say is that I'm just really concerned about reentry as it relates to recidivism. People just kind of going the revolving door, going back into jail or being further justice involved. And I want to see I want to have a sense of sort of a survey, lay of the land of what we've got in terms of resources, where the gaps are, where we can improve. I think that's just one area where we haven't been strong as as co-communities, if you will, with Bellingham, Whatcom County, and the small cities in terms of having robust systems to help people so they don't go back to jail. And I want to understand what the impeding factors are, including housing, jobs, et cetera, criminal history. So I just want to, this is a topic for discussion at our joint meeting next month. And I wanted to get a sense from the group what people were thinking in terms of, where we can go with this, with item C, the reentry and warm handoff. So that's why I just want to bring that up.
As Dan mentioned, we are kind of queuing up, and we're going to glean any wisdom that we get from you all, or questions that you have about from our joint meeting. Perry, I know that we're leaning on you a lot in this meeting, as we used to lean on Miss Deacon. So we really appreciate your presence and your knowledge, both. One of the items in this particular in letter C, you can see is talking about connection gaps. And I think when we put this together as a group, we really wanted to make sure there's special highlight, I guess, about our crisis stabilization center and ensuring that there are not gaps. And if there were, kind of earlier in the process, I think that's why we put special mention on reentry and warm handoff, because it was so brand new. And we wanted to make sure that that was not going to be something causing a problem on either end, either the connection to people coming into that, or when people leave and how well they're transitioning. Not to put you on the spot again, but do you think that's something that we might be able to talk about in our joint meeting? And would there need to be any preparation to talk about that? Or do you have any anecdotes to share with this group today about connections and either opportunities or wins currently? And I'm fine to kick it off to our joint meeting as well, Perry.
Sure. Yeah, no, I think that it's a really important discussion. And, I continue to sort of get my head around this and the steps that are necessary within this. Couple of things I think that folks and some people obviously attend. We have a Crisis Stabilization Center Advisory Committee. And I think one of the things that was implemented there and is discussed there that involves first responders, the providers, the folks that are involved. I think that the other folks that need to be involved in that kind of larger committee certainly would include possibly the supervisor of the jail juvenile behavioral health program that would be responsible for the reentry individuals and the crisis, response individuals that are on the front line of that, meeting with the inmates and et cetera, and responding and keeping some of that data. We also have initiated, and Mike Hilly is a component of that. We've initiated a Crisis Stabilization Center Development Committee. It's a smaller group that's really trying to take a look at the process of streamlining admissions. For example, what problems are we running into? What steps do we want to take with that? And so at this point, we're working with the detox side with the intent of also bringing in the mental health stabilization component to that. But then also communicating really closely around, again, what are we running into? What are areas that we can sort of smooth out? And it's in a bit of a smaller committee, so that's a little more active, communication in terms of steps that we're taking. So I've really appreciated Mike's time, and also Rob Sullivan is the manager director of the detox facility. And so the idea and thought, I think, just in general, is taking a look at our capacity at this point. One of the things that was mentioned earlier is that what first responders are finding is that the facility is full. That's not completely true. I've got some of the statistics at this point. What's happening is the side, we have 16 beds for the detox component, is generally pretty full. They've been running at 80 or so percent bed utilization. And so we are seeing that success, a victim of our own success, to some extent. The mental health stabilization side is running a bit lower for a couple of reasons. Available bed capacity due to workforce has been a challenge. And so they currently have an available bed capacity of 13. They moved from 10 available beds to 13 in September. And, again, workforce challenges that are going on there. So those are a couple of the dynamics that we're focusing on, and feeling like we want to continue to have that communication from the first responders, continue to have communication really closely with the staff that are working there, implementing some steps that will really bring us some documentation around denials. And then finally, what we've really moved into that I think is going to be important is making sure that those individuals that are admitted are meeting, I'm not sure exactly how to say this, and so forgive me, but that the individuals that are admitted, for example, to detox are the priority individuals. That is, those are individuals that are coming from diversion sources that are in need of that. And then, of course, the question comes up of individuals that maybe don't fall into that particular priority class. Because if we don't do that, what's going to happen is the detox facility is likely going to be at capacity all of the time. And so we run into the same, the same challenge. So we're trying to take a look at that dynamic. And so maybe I've gone into too much detail, Mike, just in regards to sort of the communication, the groups that are meeting and some of the focus that is occurring. But I offer that information, and that's how we've been approaching it, and really coming up with and discovering that's like, okay, we're at capacity. Do we have the right people that are being admitted, or is this, individuals that that maybe don't necessarily need, they just happen to be there and didn't necessarily need the level of services that are provided at the Crisis Stabilization Center. Obviously, this brings into the point, the 24/7 facility that we're talking about, and some of those other components. But with all of that in mind, so hope I wasn't rattling too much there. That was some important information.
No, I see we've got two hands up. I'm going to get right to those. Just very briefly, Perry, I think it's a very appropriate amount of detail, and you're really hitting kind of what I see as one of the spirit of this task force is, do we have the right people where we want them? Do we have the right people, behind bars to keep our community safe and for their rehabilitation to begin behind bars? Do we have the right people in behavioral health facilities? And are we using that to the most optimum use? I think you're just kind of sharing out that, hey, this is a scarce resource and we want to make sure that it's really targeting. With that, I want to go to Under Sheriff Chadwick and then Arlene.
Again, just kind of going back to one of the priorities there. As far as the jail and whether it's re-entry specialists, navigators, I know we've struggled to kind of keep that, and we've worked with the health department in the past. I believe it's been the last two budget cycles I've put in the budget for a navigator position within the jail, because I think that's important to have, and probably more than one, so that we have that 24/7 coverage. Because of a lot of times, there's obviously resources outside of the correctional facility, but if they're not there to meet them at the door when they're released, they're missing that opportunity. So I think somebody within the jail that knows exactly when people are going to be released, and if they know that that's going to happen in the next day or the next half a day, they can make sure that they coordinate with the appropriate resources, so that when somebody's going out the lobby door, there's somebody there, or there's somewhere for them to go. And I think that's kind of what Dan was talking about. I think there's a missed opportunity there, and Perry can probably echo this. It's hard to find somebody and maintain somebody in that position for a significant period of time. So it just goes back to that workforce issue. But I would like to see more of those within the jail, so that there's somebody that's knowledgeable of releases and the resources that are available, so that we're not missing that opportunity once they leave the lobby.
Doug, thanks for that. If I could just ask you just clarification, Perry talked a little bit about a contract that's kind of gone unfilled for a while with a specialist within the jail. You used a different term, though. You used a term of navigator. Would you just inform us, do you view that kind of as on top of and additional to the Lifeline Connections contract that we understand is about to be fulfilled, that we really need more than what we even had before? And could you just touch on that briefly? Do you see them as different or similar? Or?
No, I mean, I see them both covering similar duties and responsibilities. Really, the focus is making sure that whatever facility, whether it's the Crisis Stabilization Center, one of our corrections facilities, once their time is done and they're ready to be released, that somebody is aware and they have the resources, whether it's housing or mental health treatment, substance use treatment. Because again, once they leave that facility, while they're here, if somebody's here and they're participating in a medically assisted treatment for opioids, and then they go out and they don't link up with the right provider, then potentially they just go back to what they were doing before. And hopefully, I know they work very hard before they get released to try and at least provide something that gives them 30 days at least before, covers that gap a little bit, even if they don't see somebody immediately. But just making sure that they're connected with the resources as soon as they leave.
Thank you for that clarification. It's really key. And I know a lot of communities are using positions like this, and this term navigator is getting some more just street traction, so to speak, right? And I think it can be from a community health standpoint, but for us in terms of incarceration, I just really see the role that you're talking about is extremely critical. Our hot team, by the way, works with folks like that and provides some specialists like, hey, you need housing. You don't have to know everything about that. Why don't you give that person to us and we can walk them down that road. But yeah, no, really critical. Arlene, then Perry.
Can you hear me?
Sure can. Thanks, Arlene.
Okay. Oh, no. Okay. Am I muted?
No, we can hear you okay, Arlene.
Regarding what Doug just said, there's I think a bit of a difference between navigators and the counselors in the jail. I do think we need both. And because that warm handoff you're talking about is complex, right? It has so many layers to it. And that was the program as we received a report in Law and Justice Committee from the Goodwill organization was doing all of that reentry work before COVID. And they've been avoiding doing it or not comfortable doing it because of their fears about getting COVID. But it was very extensive, including housing, jobs, clothing, classes for how to get along at work and deal with your boss and so on. And it was very, very extensive. So if we need any instruction about program, we can certainly ask them. Back to crisis stabilization, having worked there for 10 years myself, I saw in an intimate way what the problems were, and there is some sort of glitch having to do with, as Perry said, with denials and with the standards of who can come there. So if there's controversy or a concern, that's the area where it needs to be straightened out and clarified. Not that you can be perfect about it, because there's so much subjective in the behavioral health field anyways. But too many times there were empty beds in crisis respite, as it was called at that time. And that happened because of the denials. Okay, so but why is there a denial? Because there are certain standards that have to be met in order to be accepted. So the question is, what are they? And are they the right ones? And do we have any flexibility about it? And who will make those decisions ultimately? So very important piece of this puzzle, because the beds should be filled up. And if they're filled up all the time, then more beds are needed. I mean, this is not a complicated idea. So the question of the right people is, that's a big question, obviously. So I hope, I wish you well with that, Perry, and I hope, that is worked on and straightened out. As far as addiction services, they were almost always full. In fact, they used to tell me that they turned away 50 calls every month. So they never had enough beds, and whatever beds we have, they're not enough. And I'm just telling you that on a practical basis, the numbers are very high. There's another piece to this puzzle, which is, I don't even know if we can address it at all, is that some people try to get in to both or either program so that they'll have a place to sleep. So I don't know what to say about that, except that there's a certain percentage of people who will do that, and they know what to say in order to be accepted and so forth. So that's okay. That refers to the larger issue of homelessness that we are also struggling with too. And obviously we can't help but see how it comes into the other issues that we're talking about.
Thanks, Arlene. Perry?
All really good points, Arlene, that you're making there. And so, if I can back up just a little bit, at least world according to Perry, in terms of my experience, that I really do like the idea that Doug had presented around a navigator or whatever the term, and there may be some real importance around the verbiage there. But one of the things that's happening, I'm seeing out there from state and even more local levels is relative to the workforce issue, is really taking a look at the expectation or the level of training and education for the individuals that are providing the services. I don't know if folks are aware of it, but I work within the prison system, providing substance use disorder services for quite a length of time, and really ran into this challenge of where very, very challenging clients and oftentimes individuals that were fairly new to the substance use disorder treatment field. And that's not really a good match for any number of reasons that you can probably imagine. For example, the jail is a really challenging place. Folks can be very, very motivated to say yes, yes, yes. And the idea and concept is I want to get out of jail, which makes perfect sense. But then the motivation isn't necessarily there upon their release. My point being that one of the avenues that we're approaching and working with Lifeline Connections, for example, in the reentry position is taking a look at the possibility of a additional peer counselor staff that are closely supported by a supervisor. And so oftentimes, that process of, number one, what's obviously important is the reentry individuals need to know the resources that are available within the community. Make that connection. But then honestly, and I know that Doug and others are really aware of this, being at the right place as the individual is released to walk with that individual over to the facility and have them, get connected to that appointment is a huge portion of that step of reentry. And then it doesn't end there, obviously, but if there isn't somebody there when the individual is literally released, the likelihood is diminished, dramatically. So that individual could very likely be a bachelor's level individual or a trained individual that can do those kinds of actions, as opposed to maybe the more sophisticated, working with the relationships with providers within the community. So we're looking at that to expand the options that we have in regard to keeping those positions filled, because before, oftentimes those positions for the jail behavioral health program were master's level individuals that were licensed, that were individually licensed, because of the liability that comes up in terms of providing those services and any number of other components. So we're taking a look at that piece. So knowing the resources, physically being present at the point of release, and then the communication, obviously, between the jail and the reentry individuals. If it was, the process occurred a little bit earlier, the individual's going to be released at 11 instead of 12. Those kinds of things. Secondly, to the point that, and I really agree with also what Arlene was talking about, taking a look at denials and that are occurring at the Crisis Stabilization Center and really understanding that. I try and stand in the middle of that, because there are really good reasons that individuals are denied admission at the Crisis Stabilization Center. But for the first responder, that's just a frustrating process, obviously, that it's like, what's the problem? We have put together through the Crisis Stabilization Center Advisory Committee a admission considerations that does specify in a more general way for law enforcement and first responders. It's like this, these individuals are individuals that are likely appropriate. But for example, if an individual is on oxygen, they're not licensed to have oxygen in the facility, they can't accept that. Or if the individual has a primary medical condition that they cannot address, the person needs to go, and et cetera. So I do have that. And I can't remember, I think that I've actually provided that to this group. If not, I'll send it to Jill. I've sent it out to the sheriff's office and Bellingham PD and some of the other small cities information, and more than happy to. The intent of that particular document was to give some general information to the first responders of, okay, do I want to consider this individual? You know, it is voluntary, you know, for example, et cetera. It's a simple one-page component. And so we are absolutely looking at, okay, denials for admits. Let's try and track that and keep some of that information so that we're understanding why that is occurring. And the other piece it strikes me is to be able to support the providers in saying, okay, so if this individual, as Arlene mentioned, it's a Friday, it's raining, and the individual is looking for a place to sleep, understandably so, and some food. Do they have an alternative in that relationship and communication with the shelters? You know, for example, to say, we can't admit you here, but we do have a location if you'd be willing to consider it, et cetera, and do a warm handoff in those particular directions so that that individual is getting the resources that they need, but is not being admitted to the detox unit because that's not something they're actually motivated to do. So those are some ideas that are beginning to generate and develop around, yes, okay, this isn't a good fit, now what? As opposed to, no, it's not a good fit, goodbye. Because then first responders get frustrated and don't want to bring the individuals out. And, you know, others seeing it from that distance are saying, well, they're just refusing to admit people, which the providers receive their funding and payment through admissions. So they're fairly motivated to admit the right person, obviously, to the facility. So hopefully that helps in just responding to some of the information folks have shared.
Thanks for that, Perry. That's really helpful. Anything else on this item? I'm just going to bring up, just to highlight to you all, we actually listed reentry and warm handoff 3 times in our list. And I'm lifting that up to you all to say, 1, how important it is. 2, we thought it was really important to list out some nuances, and we have hit a couple of those. One that this committee was particularly interested in is making sure that our transitions and warm handoff and reentry was really tight around the new crisis stabilization center. And that was specifically listed. Another one was the Perry, which he's talked about a new position. Could that function outside the jail? And then we've also had, we have a third one, which it may have been from Dan, but I'm not quite sure, that was really regarding the Blake decision. So realizing that we may have some individuals re-entering quicker than we might have thought originally in our system. Were there any behavioral health treatment resources that were necessary? And I'm just wondering, from y'all's perspective, and maybe those, especially law enforcement, who might know a little bit more, has the bow wave from folks being released from Blake decision, is that more or less in the rearview mirror? Is that still a very current issue, and or should we be devoting any time thinking about or brainstorming behavioral health treatment resources for individuals affected by the Blake decision? So with that, I'll stop. And
So Mike, for me, I don't have a definitive answer that would guide us, you know, in a direction right now. And honestly, I think perhaps that's also a question that we would have to bring the prosecutor's office to, you know, assist in answering that. So right now, I think it may be a bit too early for me to give any type of intelligent answer, because certainly an answer with that should come with data, and I don't know.
thanks, Chief Tanksley. Councilmember Hamill, I see your hand up.
Yeah, I don't know if the others are. I had a hard time hearing Chief Tank. I think maybe it's just the audio that I'm listening on, but so there's another piece of this, and that's ESB 5467, which is the legislature's answer to Blake, and that's the one that we all know, which is the one where it requires the individual to have 2 treatment interventions before they can be charged with any type of crime, which I just don't understand how that works. So I think there's some advocacy that needs to happen with our state legislators when it comes to reworking that particular bill, because I just don't think that that's realistic or it would work. I would like to, see the efficacy of that. Let's, what happens with those requirements of the 2 treatment interventions? Is it working? I don't have good faith that that does. So I think that there's, this is to be decided, but I think that this group could weigh in on what that looks like. I think, Blake there was 80+ million that was set aside for treatment across the entire state of Washington. It's not enough money. The service delivery is not up to par. So I just think that I think we need to take a stand here in terms of interventions and treatment that's meaningful, realistic, and will actually help people. So that's where I'm at.
And Dan, just to clarify, when you said ESB, I think I wrote it down wrong, but did you mean 5476?
Oh yeah, I'm sorry, I might be a little dyslexic here this morning.
I very well could have heard wrong. I just want to make sure. So it's the one that the legislature passed and kind of in relation to the Blake decision is what you're.
Yeah, it was their response to it. So as we all know, state Supreme Court just made the ruling and didn't provide a lot of options for folks. And I get the intent. I totally understand it, and in theory support parts of it. But Ann Deacon keeps coming back up in this discussion. But Ann was very clear. She said if you don't have the intervention and the treatment capacity, it's like 2 halves of a whole. You've got to have that in order for people to get well. And addiction's a disease, and if you're not providing the treatment options for it, then it just I don't get why. I just don't understand why it would be. It's not even a matter of civil liberties to me. It's a matter of something that a person can't control. So having the interventions is important, and I would like us as a group to make a recommendation to steering and then to the full task force on what we think would be a better alternative to that bill in terms of, and I'm not saying throw people in jail for addiction. That's not what I'm saying at all. But I'm saying this keeps going back to the workforce issue and the capacity issue. Have a meaningful intervention for people. That's all. And I know it's very complex, and but we've got to have that. And it might exist outside criminal justice.
Thanks for that. I think I heard loud and clear that's still really closely intertwined into this whole discussion of reentry and warm handoff. A little too premature to table it. And I was not necessarily advocating that, but I did want to get kind of a temperature check, especially those from law enforcement. I'll probably move on to the next one, which we will just tee up in this meeting. I want to save the last few minutes. Obviously, if you all have any comments, if we have any public comment, we'll make sure we get our list of topics from you all for our combined meeting. I did want to tee up though, and I'm going to use Dan's comments about substance use to tee us up into our next topic area of and unless anybody has anything they really wanted to add on reentry and warm handoff at this point, our next in terms of scoring for us was meth use. And as we're hearing both about crisis stabilization, that some people may not be the most accurate fit or the best fit based on what's going on, that we see those beds as constantly being full. Arlene has made the comments that there's nowhere near the capacity we have for people with substance use disorders to go either during a crisis, during kind of an issue, and or for treatment. So just to remind us, our committee, and I won't have Jill pull it back up, but I'll just read it to you briefly what our next topic item is, which was meth use, methamphetamine treatment and recovery. Are there additional services to provide for people who want to recover? Examine the problems of meth use and supportive housing. So that's what we listed on this particular one. And obviously, as you know, we have a member who's not here with us today, Michael Smith, who works at Baker Creek Treatment. I think it would be great to just tee up a little bit about what we want to know about this particular subject to have a meaningful discussion in our next meeting. So I guess my thoughts as a co-chair would be the following. One, get some wish list items from our law enforcement folks that are present today. What are they saying that they really need? Maybe that's something that some work can be done between this meeting and the next to bring some useful information about that. So I'd be interested in getting any feedback that you all might have. And then any other committee members about either knowledge that you have about meth problems, about possible solutions. So again, this would be more framing comments. We don't have to go completely down the line because we probably only have about 5-10 minutes, and meth is a big conversation. With that, I'll stop and open it up. And Dan, I see your hand up first.
Yeah, this one came up because it's so problematic. There's not a MAT for this one. It affects people's housing if they use or cook in their subsidized housing. That it's an automatic eviction, and anyone with an eviction within 24 months on their record is very, very challenging to house. So it contributes to homelessness. It destroys people's lives. I mean, it's just a terrible thing. I want to add though, and I know that I don't want to commandeer this agenda item, but I do want to add that I'm concerned about. I want to make sure that this committee has a heads up on problematic drugs that are on the horizon or in the community that we may or may not know about. When I was riding along with Captain Joe Frank and Andrea Day from the GRACE program, we had a discussion on Hulkies and school buses, which are benzodiazepine. I think I have that right. And that is muscle relaxants and fentanyl combined together, which I just don't understand, but I think that's a trending drug. And so I just want to make sure that this committee has a heads up on re-emerging or emerging drugs that are really impacting the community. And I know that for a long time that was heroin, it still is. Fentanyl is making its presence known. So I just want to put that out there that if we can have a heads up, this committee definitely needs to be a leader and to have that awareness. So just throwing that out there.
Thanks for that, Dan. I believe it was Under Sheriff Chadwick and then Arlene.
Well, obviously, we've been seeing an increase in meth use for quite some time. Opioids, heroin kind of was the predominant drug of choice, but we're seeing an increase in methamphetamine and cocaine again. So both methamphetamine and cocaine are stimulants. Obviously, heroin, fentanyl, the benzodiazepines that Dan talked about, those are all depressants. And what we're seeing a lot is you've got these, a lot of polydrug users. So they're using both a stimulant and a depressant. And a lot of times that's, to try and stabilize themselves. One takes them to a high, and then they want to get back to that middle point. So they try and take a depressant to get there. And it just kind of becomes this yo-yo effect. And so that's challenging. And as Dan said, other than opioid addiction, there's no medical treatment for meth or anything else like that, and it's very difficult to treat. For somebody that's going to go into treatment, and quite frankly, the resources don't exist to do that. I mean, that was from a law enforcement perspective, probably one of the most frustrating things about all this legislation was passed is they want us to divert people to these alternatives, whether it's somebody that's got a substance use disorder or somebody that's struggling with mental health issues. There's really not enough capacity to deal with the need. And So whether it's, diverting people and making a referral twice for a drug arrest, the problem with that is right now there's not a good system. So you could be living in King County and contacted twice by law enforcement, and maybe they do or don't know that you've been contacted twice. Then you move to Whatcom County and we contact you twice, and maybe you move to Skagit County and you're contacted twice there. Well, there's 6 times that, at some point, lead may work for some people. It doesn't work for everyone. So there's got to be different options and different alternatives depending on your level of addiction and if you're amenable to treatment. And a lot of people at some point, and we hear from this from families a lot, they'll call in and they'll report their loved ones for committing a crime because they want them arrested, because they believe that's the only way they're going to get that treatment. So whether that comes via drug court or some other alternative, but it's certainly a problem, and I anticipate we'll see that trend to continue. Certainly the pandemic has not helped with people's mental health conditions, and a lot of people obviously turn to drugs to self-medicate.
Thanks for that, Doug. Arlene?
I was hoping when we discussed this topic that somebody somewhere would have some new research that there are some treatments for methamphetamine use. But I'm not hearing that. And it's probably the most terrifying condition I have ever seen in over 40 years of work in this field. The meth addicts appeared to become non-functional human beings. And by that, I mean the brain is so affected that their ability to do almost anything is gone. These would be the kind of people who would have in generations ago been in a hospital for the rest of their lives and be taken care of, because they don't look like they can take care of themselves. And so it's terrifying to see it. It's just really frightening. Opioids, I think people can recover, and sometimes they are on maintenance drugs for the rest of their lives. But meth is something else. So I hope that somebody somewhere is doing this research, because it's just really a problem with no solution. But we still have people that we have to look after, and families that are desperate for help.
Arlene, thanks for your comments. Just very briefly, I just really appreciate and empathize with law enforcement. I'd only worked for a brief period of time with people, and they would come to the emergency department in St. Joe's, and it would look very much like organic psychosis. It would look for all the world that this person had a thought disorder until you gave them 12 hours. And I have never seen anything like that. I have not been in it for 40 years as Arlene has. So I don't have that life course perspective, but I was completely blown away at the altered presentation of individuals on methamphetamine. So, and just know that our EMTs and our law enforcement are meeting with folks every day who are really not themselves. And then the only thing that I was going to mention, Arlene, is, somebody did come out and do a little study on antidepressants and thought, wow, there's like this marginal benefit. There was really almost no benefit. It was barely statistically significant. So I know that people are still researching, or any of the pharmaceuticals or any of the other treatment modalities that assist people with their trauma, or, maybe alleviating that need. And I'm just finding none. Perry, then Dan.
Yeah, thanks, Mike. I would really agree with a lot of the things that Arlene had just shared. Wanted to touch base just really briefly on the referrals that Doug was making reference to relative to the Blake decision. Folks may have heard about the Recovery Navigator program that is coming on board. It's going to be connected to the LEAD program. It's actually being facilitated by the Behavioral Health Administrative Services Organization through funding that is coming from the Health Care Authority. And there's a number of individuals that are going to be part of this Recovery Navigator program. But the idea and concept, at least that I have heard behind it, is that they will be available for law enforcement to make referrals to and then connect those individuals to treatment services. And they will also track those referrals. It doesn't address the issue that Doug had brought up. It's like, well, what about if they were in King County? I don't know that there's going to be any statewide, tracking system. There may be all kinds of challenges with that. But at any rate, I wanted to let folks know that is going on. The plan was submitted by the Behavioral Health Administrative Services Organization and accepted by the Health Care Authority. And so now they're moving into kind of the steps of, okay, so how do we bring those individuals into play? The LEAD program fits very, very well with that. And so, I offer that information. Old CDP, they don't call them CDPs anymore. That's how old I am in terms of being in the field. And I too am super impressed when it comes to meth addiction. There's nothing like it. There's nothing like it on the earth as far as I'm concerned. I've always been struck by the fact that given medication-assisted treatment, which I think is amazing, an amazing resource, that the hope out there is, can we find, some kind of medication that will help with methamphetamine addiction? And I don't think that that's ever actually likely. I'm typically an optimist, but I don't think that medication process is going to be an answer. What I absolutely and firmly believe is that an individual that is struggling with methamphetamine addiction must receive inpatient treatment initially, period, end of story. Outpatient treatment is not effective. I've done a little bit of the research that I suspect Arlene has done as well. There is no effective treatment format for methamphetamine addiction on an outpatient basis. Not that follow-up care and aftercare isn't an absolutely important component. As a matter of fact, absolutely essential when an individual does get released. And so there does continue to be some inpatient treatment availability. Obviously, there's a finite amount within Whatcom County and the surrounding areas, but throughout the state, and commonly, at least in my history, if an individual needed inpatient treatment, we would look at the next available state certified facility that could receive that individual. We created relationships there, which I know that the Crisis Stabilization Center does, and I think that whole process needs to be continued and developed relative to methamphetamine, treating methamphetamine addiction. So those are just a couple of the thoughts that I think are going to be really important to continue to take a look at. I worry about the fact that most folks are probably cognizant of the fact that speedballing, it's an old, probably 1970s term, is the use of opiates along with a speed of some kind, but methamphetamine is common. And most of the research that we're looking at indicates that many individuals that are actively using opioids are also using methamphetamine. If they go into medication-assisted treatment, which I think is a positive move, what is left is oftentimes the methamphetamine addiction, because the diversion for the medication-assisted treatment is available for the opioids. And so that's one of the things that's beginning to really, I think, surface, is we are treating individuals for opioid addiction appropriately so, and should continue. But what we're leaving unaddressed is, because it can't be addressed on an outpatient basis, in my opinion, not effectively, is methamphetamine dependence that is there as the layer of the active opioid use is taken away. So at any rate, I wanted to bring up a couple of those components, and it's also something that we're focusing on in terms of the Crisis Stabilization Center development meeting, the smaller group, is taking a look at some of the topics that we're talking about here. Of, is there a way that we can better address that by, getting the individual into the inpatient treatment that's willing to accept that, of course.
Thanks for that, Perry. I'm going to go to Dan here in just a minute. I just want to call out, we had 3 people in a row that brought up kind of the divert to where. So I think part of what we'll tee up for our next time is with methamphetamine, an acknowledgement that treatment resources are either ineffectual, non-existent, or don't function. But where do we divert folks? Where is there a path that's maybe not our criminal justice system, maybe not the sheriff's car, but where is going to actually be helpful for someone? And I think that's really a key subject. Dan, I'm going to go to you, and then we'll move on to items for our joint meeting.
Well, I think Mikey just brought up kind of just exactly where I was going to go with this, and Perry did answer some of my questions, but I feel like this is mission impossible when it comes to this particular item, and I don't want to. Maybe we do pursue this issue, and if inpatient only is the treatment option, and I assume it's effective in some percentage cases, but not 100%. How do we do this? What are we trying to do here in terms of what's the action item that we're asking for here? I mean, we can ask, beg, plead with our state legislators to cancel out, take meth off the table in terms of what's legal and what's not. In terms of a House bill, you can make it illegal. I don't think people are going to stop doing drugs because they're illegal. I think that's pretty clear that the history has not been supportive of that. But I'm just trying to figure out where we go with this particular item. We know that we have 16 beds at crisis stabilization. We're a regional facility. That means multiple counties can send their people here. What is the advocacy that we're asking for? That's my question. Where do we go with this? And this is the one that I don't have the answer for. The other ones, like there's pie in the sky answers, there's low hanging fruit answers. This is one that to me I don't have the answer, and I don't know that anyone else does. So I'm just trying to figure out. And I'm sorry if I'm coming off as frustrated, but I am with this one because this is a life ruiner for people. Like you said, Mike, it's like when they present, it's like a thought disorder situation. So and these people all have families too. So I'm really frustrated. I want to get a sense from the experts where we go with this one, what we can do. It's going to be limited, but that's where I'm at. Thanks.
Well, I appreciate that. And Dan, your reflection is really well received. I think there's a lot of us in a great state of alarm, and we don't want to be guilty of admiring the problem, right, by just talking around it. I think that's why I wanted to get some sense today. So maybe we can, between now and the next meeting, task force members, I'll reach out to Brian Thane, obviously kind of our resident expert on housing issues regarding methamphetamine. We can get an update from them on what the housing authority, how they're dealing with it or not, what challenges they might have. I also want to reach out to Michael Smith, our other behavioral health committee member, just to get a sense from a person doing inpatient treatment, maybe what can we take. And Dan and others, your concerns / not wanting to go down a rabbit hole that may not have productive ends is really key. So maybe we'll bring it up at the next meeting, give it a defined amount of time, and then see if we can come with any outputs around it. I do think that conversation is really valuable, just even to get grounded in that sense of that we're really beset by something, all of us, behavioral health providers, law enforcement, and everybody in between, with how to address this particular issue. With that, I want to give just a few minutes at least. And Jill, I see your hand up, but we do need to capture some items for our joint meeting, which is coming up in December. Jill, can I turn it over to you briefly?
Yes, of course. My first question is the conversation of the next meeting regarding meth use. I want to clarify from you, are you talking about the December joint meeting or the next behavioral health committee in January?
I would leave that up to the committee. I was thinking of the next behavioral health committee subcommittee meeting in January, not for our joint meeting, unless people lifted that up as they wanted that to be a topic at our joint meeting in December.
Okay, thank you. And just to let everyone know, the items I already have scheduled for the joint meeting include reentry as discussed today. A couple other items that have come up in past discussions include: 1, staffing at Western State, shortage of facilities and the time it takes to get an evaluation. And the other item is a discussion of vacant behavioral health specialist position in the jail. And I think that came from the Legal and Justice Committee. So that's what I have up for the December agenda so far.
So I'll bring that up to the members. Is there anything you didn't hear from there that you all would like to have at our next joint meeting?
Raylene had specified that she was hoping for a report on just crisis stabilization center utilization. So just a real simple, utilization, unless others think that there's something more elaborate that should be reported.
I think that would be really useful, Perry. Thanks. Anything else? Remember, we don't have to create the whole agenda. I'm sure they'll be doing a similar meeting. So with that, if there is anything else, please feel free to reach out to either myself or Co-Chair Hamill. And we have about 1 minute left. Jill, do we open this up for public comment? Do we have anybody present?
Yes, thank you. We do have 2 attendees at the meeting today. If either of you would like to speak to the committee, please virtually raise your hands now. And no hands are raised.
All right, with that, I believe we're going to get out of here about 1 minute early. So I want to thank again all of our first responders helping us keep safe during this flood time. Please be safe. Look forward to seeing you all at our joint meeting, and thank you for the participation today. We're adjourned.